ahead and record this so that anyone who's absent today or anyone that wants to take a look at it later on can do that.
Okay, so I thought, people would really want to hear about Lyme since that's what is so much in the press. So I thought it was time to at least get started. Despite the fact that so far I haven't seen any Lyme this year, but as we were talking, Amanda and I, before we came in, that's probably because you guys are seeing the early localized Lyme disease and just taking care of it, and which is the stage I rarely see, although I do occasionally get somebody in the hospital diagnosed with the cellulitis that turns out to be early localized Lyme. So let's get, and yeah, that's fine. So this is what we want to do today with this didactic is we want to review briefly the stages of Lyme disease. We'll define what early localized Lyme disease is and recognize how you diagnose it. Truly, this is, I think, the most important part of this didactic is to understand the pitfalls of laboratory diagnosis in early localized Lyme disease. And that's important. And why you really make this a clinical diagnosis instead. And then finally, we'll review and compare the recommended treatment options for early localized Lyme disease. Okay, so this is a table that I've shown you before. It's not the best, I'm sorry, it's not that easy to see, but you basically can divide Lyme up into different phases or stages. Early stage is basically the rash. Most of the time people just, well, roughly about 60% of the time people will just have a rash. They can get other symptoms with it. At that stage, like a flu-like illness, again, the headache, the lymphadenopathy, malaise, and fever. But second stage is where you really tend to get the prominent systemic symptoms, like you will with other tick-borne illnesses. Usually with first stage Lyme, you're not that sick. You can be, but it's kind of unusual. Usually that happens in the second stage where you get the systemic symptoms. And then you get a specific organ involvement, as you can see there. It's either meningitis usually or heart block or Bell's palsy. And then the third stage, I don't like the word chronic arthritis in there, but I had to leave it in because I didn't write it. But it's basically late stage Lyme can present with a recurrent arthritis, which if you treat it, it's curable. You might be left with some residual damage in the joint that gives you pain and maybe an effusion, but you're not dealing with active chronic infection in the joint. And I think that's important to point out. And finally, the encephalopathy is where the brain parenchyma is involved as opposed to meningitis, and that's a different animal, okay? We've seen a case of that too. All right. So this period is important here. I want to stress that early localized disease, 3 to 30 days after a tick bite. Think about that for just a second, 3 days. How many antibody tests are going to be positive if somebody comes to you with only a rash for this? The incubation period's been 3 days and they've got an erythema migrans rash. Do you think their antibody tests are going to be positive at 3 days? I don't. And so we'll get into what to do there and why that's important. So your classic one is a 5 centimeter bigger rash with central clearing. The most common one is a 5 centimeter homogeneous rash. And the variants can include things that get misdiagnosed as, we've said it before, MRSA or spider bites. And then you can get the flu-like symptoms with the rash, but more commonly at this stage, they've just got the rash, okay? So there's the most classic Lyme disease rash that everybody talks about. And it is very classic, and when you see it, I don't think it's gonna be hard for you to make that diagnosis, okay? This is what you see most often, and it does get occasionally misdiagnosed as cellulitis, and people get put on Keflex, and they don't get better. We had one, I think, a year or two ago that got put in the hospital, and it turned out that that's what it was. It was Lyme. And by the time he actually got in the hospital, he had early disseminated Lyme. He had the rash was in other places. So this is what it can look like, and that can easily be confused with MRSA or some kind of bug bite. I will say, again, we don't really have spiders that cause toxins around here, so maybe you could get a bug bite that could do something like that. But again, with the right exposure history and the right time of year, you got to think about other things, including that it could be an atypical presentation of Lyme. And that's important because, again, you can't rely on laboratory testing.
Question.
Yes.
So the rash, is it where the tick actually
Yes,
bite?
it is where, that's a good point. It is where the tick was embedded. And that's actually the reason that rash is occurring, is it's spreading out. The actual Borrelia burgdorferi organism is spreading cutaneously in the tissues right in the skin, from that central area where the bite was.
So when it disseminates, you say you can get.
Then it
rash
gets into your
elsewhere.
bloodstream, and the second stage Lyme is where it goes from just your localized cutaneous lesion, it invades your bloodstream, and then you're in second stage Lyme, and that can present as, since it gets into your bloodstream, it can present as heart block, or it can present as multiple rashes like secondary syphilis will do. And again, they're both spirochetes. There's a reason they kind of look, they can be confused with each other sometimes. All right. I'm not supposed to show you this, but I'm going to anyway, and I want to thank Jill Terabula for getting it for me.
I'm going to have you back up. We've got one more question from
Okay.
Mona. Is there always a rash?
So pretty hard to diagnose early stage Lyme unless you have a rash. So if you're going to diagnose early localized Lyme, by definition, it's a rash that you're seeing. So are there cases of Lyme where either the rash doesn't get noticed or it doesn't occur? If that happens, I will say that there are people who test positive for Lyme that have never been sick. That may have been a case or two like that. And even if that's the case, they don't recommend treating those people. If you, for some reason, somebody had a Lyme test and they weren't sick, they don't recommend that you treat just for a positive test. Just so you guys know that. But try to get that across to patients. You'll never win it. Good question. Anybody else? So this is something I've been waiting for years. Jen and I have been waiting for years to come out, and it's finally not quite out yet. But Jill got an advanced copy and showed it to me, and I have her send it to me. And so what I really like about this, how many people, by the way, have heard of ILADS? Okay. Yes.
Yeah.
So there's this alternative reality out there that Lyme is supernatural and can't be killed. And that's sort of promulgated by ILADS. And this is sort of, and their guidelines are all over the place now. And the IDSA guidelines have been taken down because they were so old. So this is going to be released later this fall. And the nice thing about this guideline is it's not just IDSA, because there was a lot of criticism about, pointed at IDSA about they were undertreating Lyme disease, and there were all these groups that were like literally picketing IDSA at meetings. I used to go to them, and they would be there. This, they tried to get around that by doing, it's not just IDSA, it's the American Academy of Neurology, and it's the American College of Rheumatology. So it's not just an IDSA guideline this time. It is a guideline from 3 different specialties, all in agreement of how to do this. Okay, and so I can't resist not showing you this, even though if you look up there, it says, do not distribute.
Do not report us.
Right.
Pretty please.
I know, I'm so sorry. So this is out of those draft guidelines, is what they say, and I've got to look here. I want to read to you exactly what they say. It's just what we just talked about, an annular skin lesion, erythema migrans at the site of inoculation, just what you was asking. And you can get constitutional symptoms like they were showing. And that's where, after that, the second part of this is where it disseminates into the blood and then goes to other places in the skin, or to the heart, or to the meninges. Okay? So again, this is right out of those draft guidelines. What is the preferred diagnostic strategy for erythema migrans, early localized Lyme disease? And it says, in patients with skin lesions compatible with erythema migrans, we recommend clinical diagnosis over laboratory testing. Strong recommendation, moderate quality evidence. And then the comment that I took off another page and put on here was, the clinical diagnosis of erythema migrans assumes that a patient has had a plausible exposure to infectious ticks in a region endemic for Lyme. So if you've got the rash, you've also got to have the exposure, okay? Somebody that never goes outside and has no pets to bring in ticks, that lives in a nursing home and has a rash, it's not going to be Lyme. Okay. So why are they recommending a clinical diagnosis? Because if you're in the first 2, remember the incubation period, 33 to 30 days. Within the first 2 weeks, which is when the majority of people are going to show up, their serology is probably going to be negative. So you got to make the diagnosis clinically. And I'm going to go through a lot of slides that show you serology, which I am going to tell you not to use. Okay. So let's see, where were we here? Okay. So yeah, this talks about that again, that if you use the standard, what the CDC recommends and what IDSA recommends, which is the 2-tiered test, which is an screening EIA, which if positive, you go to a Western blot. And people with early cutaneous Lyme disease, which is localized to one lesion, fewer than 20% are going to be positive. So you can't use these tests to rule out Lyme disease. It's the opposite. And most of the time, if they have early Lyme, their test will be negative. Now, if you get out to 4 or 5 weeks there and you get presenting with multiple lesions, then you're in second stage Lyme, and it's going to be positive. But that's not what we're talking about here. We're talking about early localized disease. Everybody with me? I hope.
We'll do a quick check in here. Everybody looks good.
Okay. So there is this new thing coming out. I don't think it's going to catch on right away. I don't know where it's really going to go, but I want you guys to know about it. It's what's called a modified two-tier testing strategy for early localized Lyme disease. And that's where they use basically two different, what they call orthogonal EIA tests, either sequentially or simultaneously, to try to improve the diagnostic testing of early Lyme's with a blood test. And by that, we mean two antibody tests that measure different but specific antibodies against different antigens to the organism. So in principle, if you use them in sequence or if you use them in parallel, you might pick up more early localized disease than you would doing a standard EIA with a Western blot. Okay. And here is what the proposed change in algorithm would be. So on the left, you have the CDC algorithm and the IDSA algorithm, which is the EIA followed by a Western blot if it's positive. And then if it's early localized, they suggest that you get the IgM because that's the one-time IgM. If it's positive, it's probably real. If you get an IgM in someone with late stage, an IgM with somebody and no IgG with second or third stage Lyme that doesn't have second or third stage Lyme is probably going to be negative. I mean, it's probably going to be a false positive. Let me back up and try to say that again.
Thank you.
All right, so if you get an IgM on somebody that you think has Lyme, and especially if they don't get the EIA, which is I see done a lot of times, people get this Western blot IgM that'll be positive. If you're not in that early, if you do not have early localized Lyme disease, that test is worthless. And if you have early localized Lyme disease, meaning you have the cutaneous erythema migrans rash, you don't need that test. But that's the one time the test is truly positive is if you've got early localized Lyme disease. Any other time the IgM Western blot is positive, it's likely a false positive. So that's the only time it can be of any use, and I don't even think it's worth much there because you can diagnose it clinically. I hope that made more sense that time. So if you get something beyond that, it's a false positive. The new tier, modified two-tier, is to use two EIA tests either simultaneously or in sequence with the idea that you'll be more likely to pick it up earlier. And that's what the right side is going through. And there's a guy named Brandon that's really pushing this. Okay. Okay, so this is looking, this particular slide was a sort of a, what do they call it? Where you put all the studies together, I'm blanking on it.
Meta-analysis.
A meta-analysis, yes, thank you. Couldn't think of the word, thank you. And so these are different types of EIA tests, and the FDA and the HC there are telling you that they're FDA approved to diagnose Lyme. So these are real tests. They're not like crazy tests somewhere. And there's one I think that says HC, that means the Canadian FDA equivalent also has approved these tests. And what I really wanted to bring up to you guys is that these tests, if they're positive in early localized disease, they're very specific. Assuming somebody hasn't had Lyme in the past, which can happen too. But the sensitivity, even with these supposedly much more sensitive tests, the best you're getting is 60-something%. Not very good. And so even with these supposedly more sensitive tests, they're still pretty bad. They're at best mediocre. All right. And this is another one that's showing exactly that. I think this is actually the brand of paper. He's been doing this since about 2011, and he's got a lot of good ideas here. But basically, you're still to the point where if you're in early localized disease, you are looking at maybe a 60% sensitivity, even with the best test. And the one I want to point out to you guys on here is there is this thing called a C6. Is that on this thing somewhere? Yes. So a C6 is actually a more conserved region of the VSLECLA. And that's a protein on the surface of the organism, and this is even a more conserved region. If in my mind, the C6 is probably just as good as doing 2 EIAs, but that's my opinion because you get the same sensitivity. But again, if you're looking at early localized disease, you're still talking about a sensitivity of about 60 to 70% at best. And that's the best test. And if you think about it, that's because if you are presenting within the first 2 weeks, you don't have any of these antibody responses yet. So again, I don't care how good you make these tests, you got to make the antibodies first. And if you're too soon, if you present too soon where you haven't made the antibodies, I don't care what they do, you're not going to find it that way. All right. So that leads you to what else can you do if you can't do just antibodies? You can try to do a skin biopsy, but first of all, how likely is that to happen on a grand scale? Pretty unlikely. And two, even if you do a skin biopsy and try to culture, you get about a 40 to 60% sensitivity even on a skin biopsy. If you do a PCR, it may be slightly better, but it's still about 70% or less. And so again, I think you're left with having to go for an exposure history and what it looks like. So the bottom line in my mind is that this is a clinical diagnosis, a plausible exposure history, and a compatible rash with plus or minus flu-like symptoms. The tests we have now and are likely to have in the future are still not sensitive enough to pick up early localized Lyme. There is some talk about combining an antigen antibody test like has been done for HIV. But again, in HIV, people have at least had HIV a couple of weeks before it's positive. And it's still not, in my mind, going to get around the trouble of the first 2 weeks. I think just about any of it's going to be negative. Remember, it's not usually in the blood at that point. So if you do an antigen test in the blood, you're not going to pick it up. It's got to be early disseminated before you see the antigen in the blood. And that takes usually 3 to 4 weeks to happen. So I can't stress enough, never ever use laboratory testing to rule out early localized Lyme disease. And just as importantly, never use it to discontinue treatment if you've started it. I saw that patient 2 years ago. He was put on doxycycline for early localized Lyme. The test came back negative. They stopped the drugs. He got hospitalized with early disseminated Lyme. So you can't use them to diagnose. You can't use them to stop treatment if you've diagnosed it. You just got to do it clinically. And as you'll see, second and third stage Lyme will be the opposite. You will be relying on laboratory tests. This is the time where you don't. Okay, so now to get to treatment a little bit. So this is early localized disease, and you could use any of these for adults or children. And the nice thing about the new IDSA guidelines is they don't have a restriction for under the age of 8 not using doxycycline anymore. And I was glad to see that because remember, co-infections happen. These kids, if you've got a kid that's got Lyme, they may not just have Lyme, they may have a rickettsial organism too. So I would just keep that in mind. So if you ask me what I would choose doxycycline unless there's a reason I can't use it, a real reason, and age under 8 is not one of them. So if you've got to use something else, then you can use some of these other things. But doxycycline would be my first choice, and the beta-lactams, amoxicillin, cefuroxime, and pen-VK would be second choices. And if you notice, there are 14 days instead of 10, so you got to use them longer. Azithromycin is probably a third-line drug, and you really got to have a reason not to use the other two. And the only reason that you give it for 7 days that you would think, oh, maybe it's better. The only reason you give it for 7 days is it has a tissue phase that lasts for another probably 7 days. And so you're really treating 14 days when you use azithromycin when you give it for 7. But again, I don't think of it as a top-line drug for Lyme. I think of it as second line. And so with that, again, we're talking about early stage Lyme here, early localized disease. So first, you got to realize that what we all were taught is the bullseye rash is not the most common thing you see. You see that flat red rash that sometimes gets misdiagnosed as cellulitis. About 30% will have no other symptoms except the rash. Others may have the flu-like symptoms. In fact, it's the opposite. Actually, I've got that wrong. Only about 30% will have the flu-like symptoms. The rest will just have the rash. You got to have the potential for exposure. Remember that at least 2/3 of people will not remember they were bitten by a tick. You should always look though, because guess what? You can have another tick on somebody. So if they're early localized Lyme disease, look them over for another tick. There may be another one somewhere. So treat based on clinical diagnosis. Remember that about 75% of people with early localized disease will not have positive serology. And if you treat them at this stage, I didn't talk so much about this and didn't show it to you, but if you treat them early enough, they will never develop positive serology. So don't go back, say, in a week or 4 weeks and say, oh, let's see if you really had it. Well, if you treated them correctly, they may not have it. It doesn't mean you were wrong to treat it. It means that you treated it early enough that they didn't get the antibody response to ever develop. Okay? So if I can stress nothing else, never stop treatment for early disease just because for some reason you did order a lab test and it came back negative. Just don't do it. Okay, so that's all I got. Anybody want to ask any questions or have any comments?
I have a quick question. Would you, if you treat someone for early Lyme, and would you follow up with them and then maybe test for co-infections like Babesia, which wouldn't be treated with doxy?
Only if they were
If they were still sick, right?
if they were, or if they had anemia when they came in, I would have said, oh well, maybe I'll look for Babesia too or something. But if they're not sick, it's a good point because not everybody with Babesia is sick. But I don't routinely test for Babesia when I see just because it's been fairly rare up here. It might be worth doing in areas where they see it more clinically. I know now that from what your research has shown, there are ticks up here that have it.
Right, about 10%, at least
Wow.
10% do, yeah.
So maybe I should change my practice and start doing that a little bit.
Oh, no. This is also out of my realm, but there are PCR tests for Anaplasma and Babesia. Is that something like expensive? Yeah. Will insurance pay for it if they did have the EM rash?
We have someone here that can answer that better than I can.
The PCR is more expensive. The insurance typically will pay for it. It depends on your insurance, of course. The turnaround time on them, it's not something we would do in our laboratory. It would be sent out to a reference lab, and the turnaround time's about 4 days. They do have panels that will test more than just, I think it tests up to what, 4 different, so it has the Babesia and that.
Yes.
So
we were just talking about that yesterday. There's a
Mayo has a test panel that tests for Babesia, Ehrlichia, and Anaplasma, and the Borrelia.
Yes.
So.
And that reminds me another point. PCR for Lyme is lousy.
Yeah.
Don't rely on PCR for Lyme. It's about a 20% sensitivity is best.
Yeah.
Which is why it's not included in this Mayo panel, because they know it's not going to help you. Right. So the Mayo panel that Diane will show you, because we're going to put it up on the side at some point, does not have a PCR for Lyme built into it because it's lousy. Don't get it. Sometimes you can get it on CSF if you want, but I've only seen one positive in my career, and that person was immunocompromised. So by the way, if you have second stage Lyme with meningitis, your blood test is almost always positive because it's second stage Lyme. And you don't really need the test in the spinal fluid, and that's what the new guidelines also say. Okay.
Anybody else? Questions or comments?
What is your take on tick bite prophylaxis, Dr. Dulles?
Yeah, very good question. And again, the new guidelines that basically say the same thing they said before. If the tick if it's been 72 hours or less since the tick was discovered and it was engorged, the official guidelines say then give them doxycycline 1 dose. And that now, I believe, in the new guidelines even includes children under 8. And so that's what they say to do. I will tell you that my own bias, and this is probably just wrong on my part, is somebody comes in and they tell me they had an attached tick, I give them a dose of doxycycline. It's just hard for people to know what's engorged and what's not engorged and how long it was. Nobody knows how long they've had a tick on. They know how long they've been since they removed it. You know. But honestly, the reason those guidelines exist like that is because it takes a while it doesn't happen right away with Borrelia burgdorferi. It takes a while for it to get transmitted. It has to be on you a while. At least 24 hours, I think, is the cutoff before it even starts to transmit the Borrelia burgdorferi. Unlike things like Powassan, which I think happens in 15 minutes. Mm-hmm. Leanne's nodding her head, so maybe I got that right.
Yeah.
Will they come?
Islets people will argue with you though and say that Lyme is transmitted within, a few hours, but I don't think that's the consensus.
So I think for me personally, I just don't know what else might have been in that tick. I don't know whether doxycycline prophylaxis for anaplasma works or it's not been studied to my knowledge. And so I'm out in territory that I really probably should not be at, and I should probably follow the guidelines, but I don't.
So we have another question from Mona, who's asking, if you treat a patient for 10 days with doxy and a week later they come in with an engorged tick, do you retreat?
So if they come, yeah, you'd give them a dose of doxycycline. I would. So if they just got a tick that's engorged, they'd get another dose of doxycycline out of me. The reason for that is there's not immunity to Lyme. There's many, many strains of Lyme, and you don't develop immunity. And so, yeah, if they come in with another tick, they got to have some more doxy. What else?
All right. Did we want to let Vanessa ask the question that we were going to defer to Diane last week?
Yes, please. I forgot what the question was, but she had it.
Well, I have it.
You got it ready for it.
Good.
So I think we're talking about the Babesia panel that we have and that just reports of IgG titers. And then I think you're saying IgG, I come to know why do we report an IgG if you really want the IgM titers for Babesia?
That's a good question. I have to do a little more research on that because all of the testing that we've got, I haven't seen anything for the IgM, and I don't know if it has to do with the immune response or not, or the way they can detect it.
Okay.
Isn't the PCR better than
The PCR is
Okay.
better. The PCR is better.
Because for some reason, when we send our tick panel from E-Town, it just is just included in our tick panel is the Babesia IgG titer.
Yeah.
Yeah.
I wonder if there's any way to change that panel.
Let's see.
Yeah.
It would be nice if we could change your panel so you could get the PCR test. In fact, you should get this Mayo tick panel that we were just talking about. That's what you guys should be getting, and not the serology stuff, because it's much better.
Yeah, because the IgG is the only, I'm looking at the panel.
So nice to have all these extra
Yes.
resources.
Yeah,
on board.
It's just telling us that Mayo's only testing for the IgG, and I'd have to really do a little research to find out why there isn't any testing other than the PCR for the IgM.
Diane, who would they contact if they wanted to get this Mayo panel that,
Well, you could order
It goes through CVPH.
You just have to order it. It's not built in the system yet, but you could just still order it as a Mayo PCR.
the code I wrote
Yeah,
down?
it's T as in Tom, K, PNL, and that's the tick-borne panel. It's a molecular detection, and that has the Babesia.
Okay.
Done from whole blood. It's New York State approved.
And I will give Jen Beveridge credit for showing it to me for the first time. It was great.
Yeah. So you just need a lavender top, so just a whole blood. I was trying to see.
And they are going to build it in, right, Diane?
Yeah, we're going to build it in. It might take us a little while just because of our manpower in our laboratory information department right now. We've got one person, so she's a little overwhelmed with a lot of, yes, yeah.
All right. Well, we are just about at time. Are we gonna let everybody go?
Anybody got anything else they want to throw out?
Any other questions?
All right, well, if anything comes up after the session, you can certainly reach out to me and I can put you in touch with any of our hub members here. I did send out the CME evaluation form ahead of this meeting. And Jill, yes, you want to pipe in, Jill, because I lost the chat that you mentioned to me earlier. Still on mute.
Unmute, unmute. Well, I'll mute her.
Oh.
Push on the
We're
button.
having a mute war, sorry, go ahead.
Hi. So just an update, we added information to the website on the individual tick-borne infections. You can get to the tick-borne site by going to the Project Echo page on the hospital's departments and programs page. And I believe we have also sent this out via email.
Yes, I wanted you to be able to show the site, but we're a little bit late now. We'll do it. The first time when we come back next time, I want you to show them how to get to it.
Okay.
Okay, if that's okay.
Yep, and I can send the link out right after this session as well.
And by the way, you can't go on the intranet to get it. It's cvph.org. If you type that into Google, then you can get to the site. But it's not the intranet site. And that's important for you guys to know. Because it doesn't say. Right, Jill? Is that right?
It's on www.cvph.org. Go to departments and programs and look for Project Echo.
All right, that's it.
Thank you.
Thank you, everybody.
Bye-bye.
Bye.